Worldwide, most people require a treatment with a medication at some point, and many of us experience side effects. But the science of medication safety, or pharmacovigilance, has some particular challenges in low and middle income countries such as Uganda. For example, there are very low numbers of healthcare providers relative to the number of the population. Secondly, healthcare is not always free at the point of access, and given that a significant proportion of the population live on less than $1 a day, that can be a significant barrier. Thirdly, there are multiple tribal and linguistic groups. So for example, in Uganda, 40 languages are spoken. So we have to ensure that healthcare information is available in a language that the community can understand. Fourthly, alongside cultural and traditional beliefs, there is a high uptake of traditional and herbal medications, and it can be actually very difficult to know exactly what is in them, what strength is being given, and whether there are any drug-drug interactions. And finally, many people have been brought up in a paternalistic model of healthcare whereby the doctor knows best, and it's very difficult to empower community members to actually be able to speak and challenge the medical professionals and have responsibility for their own healthcare.
Meaningful, sustainable systems to enable recognition, reporting and responding to adverse drug reactions must recognise the fundamental importance of the communities affected. In Uganda, the Community Health and Information Network promotes the empowerment of people living with or affected by the conditions prevalent in our society. Regina Kamoga is the Executive Director.
Many patients are exposed to near-miss incidents. Some are disabled, while others lose their lives in the process of receiving care. The truth is, many of these incidents are very preventable. We only need to come together, work together through concerted efforts to ensure that no one is harmed in the process of receiving care.
Adverse drug events include adverse drug reactions, drug-drug interactions and medication error. Regina's interest in this area stems from such an event in her own family.
My mother, a 60-year-old woman who suffered from many health conditions including hypertension, diabetes and asthma, was one time prescribed 1 times 3 of her hypertension drug instead of 1 times 1. Poor woman, she had all these medications she was taking every day and would have had no idea whether an error had been made. Fortunately, my nephew, who had gone through health literacy training, was able to identify this error, and then she was saved. This highlights the importance of patient, family, and community engagement and empowerment. Their role cannot be overemphasized.
It is ethically essential that where medications are to be used, there are systems in place to monitor their safety. This aspect of pharmacology is known as pharmacovigilance.
Pharmacovigilance comes from 2 root words. The first is pharma, which means drugs, and vigilance, which basically refers to being more watchful and alert about impending danger. So essentially pharmacovigilance would then root its focus in the need for us to constantly be on the lookout about what drugs can do to us, especially the harmful aspects, which we normally refer to as side effects in the common man's language. Otherwise, in the technical terms, we normally talk about adverse drug reactions. Pharmacovigilance also looks out for the good, not just the bad. The reason why we focus on the bad is because we don't want the harm to outdo the benefits. Pharmacovigilance is an ongoing process. All drugs are continuously observed for the rest of their entire use in the market.
Pharmacovigilance is often taken to mean a top-down approach from national regulatory bodies and academics, but over recent years there has been increasing emphasis on empowering the patients to recognise and report adverse drug reactions.
The patient is the only constant through the whole delivery system as they move from one point to another. And their carers, they can see things that busy health workers cannot see. The patient as well knows how they feel. They know their needs. They know how they suffer with their disease on a day-to-day basis. And they're better able to express their needs and preferences if provided with the right environment. But many times, the patients don't feel confident enough to air out their issues, their needs, their views. They look at their health worker as a small god who doesn't even make it easier, because it's true that many health workers also look at themselves as small gods, like the doctor knows it best kind of concept, which makes it very difficult for the vulnerable patient to be able to engage, to participate actively in the healthcare system. So empowerment is very, very critical.
Patients are not coming out to demand some of this information, and maybe because they do not know that they are entitled to know some of this information.
We all have a duty to play. The health workers do. They need to be alert. They need to watch and observe the patients that they take care of, to be sure that the harm resulting from drugs is not outdoing the benefits.
The Infectious Diseases Institute hosts patient advocacy organisations to enable such empowerment. Mercy Kukundakwe is Assistant Head of Patient Safety Affairs and leads initiatives to train and empower both patients and healthcare workers with regard to medication safety.
We held a patient safety training which was aimed to empower patients that are receiving care in the clinic to understand the basics about patient safety. We train them to help patients be able to identify things like, is this the right drug? Do I understand how to take this drug? What are the side effects of this drug? We also encourage them to ask questions to their respective doctors so that they understand what kind of drug they are taking and all the other requirements.
As clinical and academic researchers, our ultimate aim is to improve patient health. But when pharmacovigilance is neglected, there is a risk of undermining this aim. Moving from a paternalistic model of care to community empowerment has required a paradigm shift, but in Uganda, important advances are being made.
It's not enough for us to do all the good work and publish it and forget that ultimately we are supposed to improve the safety of medicines for the end user. And so I imagine that in as much as for the past 60 or so years, the focus has been on the health worker as the linchpin in pharmacovigilance, as the person we expect to report suspected adverse drug reactions. It's time we launched out there and got them involved in taking charge of their own medications and in participating in our drives to improve the safety of medicines, because they know and experience firsthand the medications, the challenges they encounter as they take these medications.
Patients or participants who participated in these studies, they need to understand, yes, last time you enrolled me on a certain study, but what were the outcomes and how are they helping me? Or if they're not helping me, I need to also understand how are they going to help the people in my community at a later stage in time.
If one health worker is meant to see 100 or 200 patients in a day, that's an overload. However much you want them to report these adverse drug reactions, most of them will go unnoticed because they're overwhelmed. Now, picture a situation where you empower the individual, the consumer, to report the ADRs or the side effects.
It is recognised that increasing involvement of patients in their own clinical care translates into better outcomes.
Whilst there are numerous challenges in low and middle income countries, there are also many opportunities. For example, mobile phone coverage and smartphone penetration is increasing quite exponentially. Uganda has a very young population. The median age is only 15 years, and I think an estimated 5% of the population are aged over 50. So what that means is there's a technology generation that has been skipped, and advances such as the NDA's Med Safety app can penetrate right into the heart of communities if only we give those individuals the skills and the tools they need to know how to use them.
The more they involve themselves, the more the sense of self-fulfillment, the more their own adherence improves, the more they are able to also contribute to bringing down the load of work for the healthcare professional.
All reports made using the NDA app are reviewed centrally in order to determine whether a true signal is present. These feed into the World Health Organization's global database, where dedicated teams continually analyse each individual case safety report that is submitted. But findings must then be communicated back into the communities.
This information should not just be confined in urban settings, for instance. Let them go back to the communities. Let the principal investigators themselves be the ones to go to those communities. They could interact with the leaders there, like the local council chairpersons, the police, the church leaders, or even work with the VHTs, the village health teams, to disseminate some of this information.
Community engagement and empowerment has always been very important, but the coronavirus situation has really drawn this into the light. So here in Uganda, we're coming to the end of our second hard lockdown. So what that has meant is there has been no public transport, and even using cars or riding as a passenger on the back of a motorcycle has been banned. And the only way people can travel is with specific government approval. So you can imagine the situation. People have actually died on their way to healthcare facilities, and nobody is going to seek healthcare about something that seems quite small or insignificant to them. Whereas, if there was a focal pharmacovigilance person within a community who had access to the Med Safety app, then at community level that reporting can be done seamlessly.
Involving patients and community groups will ensure that their voices are heard, their concerns can form the basis of further research, and the findings have clear relevance. At the Infectious Diseases Institute and Makerere University, we have public engagement activities running alongside our research in order to achieve this. There is no area where this has greater importance than in pharmacovigilance.